Right. So this presentation is about some of the musculoskeletal common conditions and also some of the considerations, contraindications, as well as some interventions that you perform with each one of them. So this is not a comprehensive list, but this is a list that will help kind of get you started and hopefully help you differentiate some questions that you will see on your practice exams as well as the NPTE. The first condition is your adhesive capsulitis. Typically, this is an injury that occurs from a direct hit to the shoulder, or so specifically like if an individual falls, if they play a contact sport, soccer, football, then that is what causes adhesive capsulitis. Typically, the restrictions are going to be in capsular pattern. And so the goals of the therapy are going to be to improve the range of motion with mobilization and stretching, as we previously discussed. So we're going to be looking at improving their flexion, their external rotation, their abduction. Whichever one is greatest is typically the one that you start with, right? So you'll do a distraction first if we're doing mobilizations, and then also we will look to perform whether that's going to be an inferior glide, we're working on flexion and, or abduction, or we're going to be looking to do an anterior glide if we're looking to improve external rotation. Remembering that there are 4 grades of mobilizations to take into consideration. Grades 1 and 4 are going to be during the acute phases and are going to be to reduce pain, whereas stages 2 and 3 are going to be to actually improve range of motion when pain has gone away. ACL sprains or tears are typically going to be due to hyperextension injuries. The special tests, remember, are going to be Lockman's anterior drawer. So Lockman's is the preferred test as it has a higher sensitivity and specificity over the anterior drawer. So typically your ACL tears are going to be congruent when an individual either, like in soccer, they kick the ball and go into hyperextension at that point, or an individual who, if they were running and they stopped suddenly and planted their foot and then they hyperextend their knee, right? So the goals of the therapy are going to be improve hamstring strength over quad strength and return to prior functional activity. So think about an ACL injury is due to anterior translation. So that means that my hamstrings, which are located in the back, right, need to be strong enough to basically stabilize my lower extremity. So you want to improve both quad and hamstrings, but typically you're going to be stabilizing or looking to do the quads, or excuse me, the hamstrings more. So some things, not contraindications, but considerations to take into effect. If an individual does have surgery, the first 6 weeks, they're going to be weight bearing as tolerated as well as in a brace. During this time, as therapists, we're only performing closed chain activities, meaning we're doing squats. You know, we're going to obviously be walking on a treadmill, going up and down stairs, those type of things. The brace is, in terms of when it is unlocked and how much is unlocked, is very specific to the physician that performed the surgery. But just know that they're going to have a brace on. Usually the first 2 weeks is an extension and then they start to actually flex it. You will not need to know that information. What is important to know is typically around week 6 to 8 is when the graft fails. So knowing that, remember, ACL injuries, this individual has a graft that is placed in terms of for the ACL. So during that 6 to 8 week time frame, the graft failing means that it basically starts to disintegrate. And the primary reason why this happens is because you start to do more activity. So at the first 6 weeks, you only do closed chain, and then at 6 weeks, you start to do open chain. So I start to do short arc quads, right? I start to really do more activities, more therapeutic activities that are open chain. This causes, right? You're putting more stress on this actual graft, and it causes the graft to possibly fail. Take into consideration that to return to actual prior function, if they were in a sporting activity, typically is going to be at 6 to 9 months before they can return to any type of activity. So typically, when a soccer player or a basketball player, injures their ACL or tears their ACL, they're typically just not going to return until the next season because it takes that long for it to actually improve. Impingement syndromes are typically going to be caused by microtraumas from overuse, so throwing, swimming, or some common ways that individuals have impingement. Typically, the pain is going to be noted in the painful arc, so 70 to 100 20 degrees of abduction. They're going to have a positive impingement test or empty can test, and so the goals of therapy are typically to improve all of the rotator cuff muscles as well as the scapular stabilizer. Juvenile rheumatoid arthritis, and these things can also be said for adult arthritis. So remember, the juvenile rheumatoid arthritis is that it's diagnosed before the age of 16. It is an autoimmune disorder that is going to typically impact the smaller joints, so hands, wrists, ankles. Remember, this is the time to review Boutonniere's and swan neck deformities because they're going to be related to RA. You can also have fever associated with this diagnosis. So remember, rheumatoid arthritis, with it being an autoimmune disorder, is going to impact the system overall. And so you could have fever, malaise, lethargy that's going to be associated with this diagnosis. Contraindications, you're not going to want to perform any resistance activities, no prolonged strenuous activities, and this is going to be during the time of exacerbation. So rheumatoid arthritis goes in where it's active and then dormant. So it has exacerbation and remission phases. During the exacerbation phase, basically I want to prevent contractures from developing. I want to decrease pain and promote functional mobility as much as possible. But I'm not doing any resistance. I'm not doing any strenuous activities at this point. Right? It's very conservative. When they go into the remission phase is when we actually start to do more functional activities. We actually start doing some resistance training as well. Medial collateral ligament sprains, we've talked about those previously, but remember they're caused by tibial rotation injury. So obviously the medial torsion. Typically this individual is going to present with pain and swelling and talgic gait. So the therapeutic goals are going to be decrease inflammation, protect the knee joint. Typically the protection of the knee joint is going to be doing to improve biomechanics. So how this individual squats, how they run, how they jump. We're really working to improve that. We haven't gotten to pediatrics, but one of the pediatric musculoskeletal conditions is Osgood-Schlatter disease. Typically, this is going to occur during the time of puberty, so anywhere from 10 to 15 years of age is when this can occur. And so remembering that it's typically going to be due to repetitive motions. They cause an avulsion at the tibial tuberosity. So again, we're working on biomechanics. So we want to decrease the stress at the knee when you're doing jumping, squatting, running, because basically what happens is, layman's term, Osgood-Schlatter. So you have an avulsion at the tibial tuberosity. It's just caused by rapid growth. The hormones cannot keep up with the amount of activity this individual is doing. So this microtrauma over a period of time develops into pain. And so typically during this time, we're going to want to work on, the first line of defense is going to be to stop activity for 1 to 2 weeks. And then we're going to resume activity slowly with introduction of how to perform those activities at a better biomechanical load. Osteoarthritis is chronic degenerative disease, and typically this is going to help occur in the weight-bearing joints, remember. So gradual onset in large joints. The goals of therapy, typically if somebody's coming to your clinic for OA, is just going to be reduce their pain. So we may introduce some modalities. Again, joint protection, body mechanics, weight loss, aquatic therapy could be key. So some of those key attributes that we talked about previously would be important at this time. Patellofemoral syndrome is an overuse injury disorder. And so typically, again, this individual has anterior knee pain, pain with prolonged sitting, pain with ascending and descending stairs. So one question that students typically have is, how would I differentiate osteoarthritis from patellofemoral, in that they have basically pain with functional activity. Typically is the presentation of the pain. So patellofemoral syndrome, they typically will point directly to the patella. If you ask them where is their pain located and can you point to it, they will point to their patella specifically. Their index finger will go to their patella. Whereas with osteoarthritis, even if it's a knee pain, typically they'll grab their knee with both of their hands and just say, "My knee just hurts," right? So they will give you a more vague type of response. Um, how you can test it, right? Patellofemoral is typically due to weakness in your vastus medialis. So in patellofemoral syndrome, the patella is tracking laterally, so it's tracking out because you have a weak medial quad. So a way to help correct this issue is that we strengthen the vastus medialis through electrical stimulation, biofeedback, and just general therapeutic exercise, right? Toe hip arthroplasty, the big things that you want to take into consideration are the different types of, the different approaches that you can take, and then also what is contraindicated in terms of movement. So you have an anterior lateral, so you want to avoid hip flexion greater than 90, extension of hip, lateral rotation, and adduction, right? Direct lateral approach, avoid hip flexion greater than 90, lateral rotation, adduction, posterior lateral, hip flexion greater than 90 degrees, adduction, sorry for the typo, and then medial rotation. Okay. Some contraindications or considerations is that any individual that has a surgery, whether it's toe hip, toe knee, ACL repair, they're an increased risk for DVT and pneumonia development. And then total knee arthroplasty, you want to take into consideration typically if depending upon what type of knee joint was replaced is depending on their weight bearing status. So if they had a cemented knee, it means they're weight bearing immediately after the surgery. So typically if they had surgery at 5 a.m., the therapist the PT is going to get them up hopefully by 2 or 3 in that afternoon. They're going to be weight bearing as tolerated. Non-cemented, they're going to be toe touch weight bearing, right? So make sure that you pay attention to that part because that's going to be your answer, whether it's a cemented or non-cemented. Cemented basically means that at the time of surgery, the joint that they put in, right, is solid. And so you can basically put as much weight as your body will allow. Versus non-cemented typically takes about 6 weeks for it to become solid. And so you're only toe touch weight bearing because if you put your full weight through the joint, it would not be able to hold. Okay. Another thing you want to take into consideration is that you need about 90 degrees of knee flexion to be able to go home. So think about you need about 90 degrees of knee flexion to get into the car safely. Right? So these are just some specifics within musculoskeletal conditions, some indications, considerations, some treatment options that you may be able to see, utilize, and kind of hone in on when you're answering some of the questions for NPTE. So I'll see you next time, and thanks for joining.